the diagnosis, but also for the molecular testing, which can be done and is being done on cytologic samples. So this is an example where this represents a really good cell block with about hundreds of cells. You need at least about 500 tumor cells. That basically should be the goal. Obviously, you can't really predict the outcome of cell block collection, but if you optimize the specimen in such a way that limited amounts are extruded out for smear preparation and majority of the specimen is relegated to the formalin container using a clot method, and that will yield good examples such as this with frankly outright malignant cells. So what we do over here, this is where tissue conservation is really necessary. Fewer and fewer IHCs should be utilized for your diagnosis, a TTF1, P40, and if need be, a synaptophysin for neuroendocrine differentiation is all what you need, mainly because what you need is 15 to 20 unslain slides which are cut up front, and those are sent to the molecular lab for basically processing it further for NGS testing, for determining what the status as far as molecular alterations go. So this is basically what the guidelines are. But the reason I have put this up for you is that take a look from 2018 to 2023. So many changes, so many updates. So this is basically a very rapidly changing landscape as far as what data as well as literature is showing for the molecular aspects of lung tumor. It is a rapidly changing field, and mainly I think it's the oncologist which really needs to be kept updated for it. But again, your job over here comes to going to the previous slide is provide them with a very good sample so that tissue conservation, after it's applied, you get at least 15 to 20 unstained slides, and that you can submit for molecular testing and further treatment that may be applied for those cases. So then again, after treatment is instituted for these tumors, then susceptibility to that tumor is important. And for the individuals who are working in a cancer center scenario, these really are important and again play a role as diagnosticians too. Then resistance to the therapy and then tumor immunity all come into play. So genes to be evaluated, this is from last year, 2022. So again, like I mentioned, EGFR is really important to be looked for and found. NGS would be ideal methodology for this. ALK, which is a fusion alteration, which needs to be looked for, NGS, but along with that, if necessary, even IHC or FISH can also be used for detecting this fusion. ROS1, which is extremely rare, 1% of lung adenocarcinomas may display this NGS, but alternatively FISH and IHC are available. And then again, it's a long list, and again, rarer events that can also be detected by NGS testing. So this is a more updated, more current landscape of genomic alteration. I think this is a great pie chart which Paul Vanderlaan has tabulated. He keeps updating it and I keep borrowing it. So full disclosure, this is not the handiwork of myself, but Paul, who's currently the editor of the Journal of American Society of Cytopathology, primarily a cyto as well as a thoracic pathologist. But again, what he has basically flagged out is non-targetable mutations. Okay, we find these, but no treatment currently is available for these. But what we can do with NGS testing is we can find EGFR mutations as well as KRAS mutations or KRAS G12C mutations, and these will be the bulk of them. And for these, targets are available, meaning thereby treatment can be given, which can be non-surgical. So personalized genotype directed therapy for EGFR, again, 15% of adenocarcinomas can display this. And again, these are sensitive to TKIs, which is again a treatment modality. There is resistance listed over here. And then again, The drugs that are available are listed here. Again, some of them have very difficult names, and I have a hard time even remembering these, but it's a long list. This is just for general information, not something which you or I need to memorize, but certainly oncologists need to be familiar with these, and probably with the most current available version, which may be used for EGFR. The same thing applies for KRAS. Basically, personalized genotype directed therapy is also available. And again, these are very common. Approximately 20 to 30% of adenocarcinomas may be displaying this, and then mostly noted in smokers. And sotorasib is basically one of the more commoner drugs that has been used, at least till last year. And currently, there may be other drugs that may be more rapidly gaining acceptance. The list is long: BRAF, ALK. For ALK, I just want to flag out that there is an IHC which has been used, and again, use D5F3 or 5A4 antibodies. This has had a long-term recommendation, and again, we use this in our laboratory. And I mean, NGS is certainly ordered on our specimens, but again, this is really something which can give an answer to very quickly on a almost like a 24-hour basis to our oncologist for further analysis. So again, like I mentioned, ROS1 also has personalized therapy available, but this is again a very rare event to be detected in approximately 1% of lung adenocarcinomas, and also has two of these drugs which are available currently and have been successfully used to treat it. So there is an expert consensus that ROS1 IHC can also be alternatively used. I won't necessarily advocate it, because if you are ordering NGS testing, a full panel, in our practice, and you can look at the Cornell website, we use a commercially available test which is called Oncomine. It has about 143 genetic alterations listed in it, which basically covers the majority of these alterations which may be found in lung cancers. Then pembrolizumab is definitely one of the drugs which has certainly been very successfully applied as both a first-line and second-line therapy for some of these non-small cell lung cancers. This is basically PD-1 therapy. And again, certainly can be for PD-1 detection. Certainly we can use NGS, but again, there is an antibody available, and IHC, again, a rapid response for treatment can be implemented on this based on staining. The staining should be really nice, sharp, and crisp. Like you can see, at least 50% of the tumor cells should display it. This is low staining, and again, a low number staining such as 1 to 49% of the cells displaying this would also be considered negative. So this is the PD-1 scoring criteria for FDA approved companion diagnostic test. Clone is this for pembrolizumab. So this would be a high expression of PD-L1, high expression, and again, use this as a benchmark. Nice distinct staining, and anything less than this should be disregarded as a negative call. So this was a little bit about molecular testing. Again, NGS is expensive, and it is actually tough to validate, but again, you can use it as a modality which can be outsourced to a commercial laboratory. We have done it before. We implemented it in our own practice, and really has gained quite a bit of acceptance for treatment of these patients. So just shifting gears here, salt and pepper chromatin. Again, this is a term we use for neuroendocrine tumors and carcinomas. Carcinoid tumors, again, rare tumors. These are usually well circumscribed. These can be both centrally or peripherally located. And basically, these have a low metastatic potential, but current concept is that it should be considered a malignant tumor. What does it look like cytologically on a smear? First of all, the cell types. There are basically several different cell types. You can find plasmacytoid, oval cells, round cells, spindle cells, an admixture of all these cell types, but predominantly you would expect to see a plasmacytoid uniform pattern for a for a for a carcinoid tumor. Rosette formation, such as noted over here in this picture, central space here, and the cells are nicely aligned so that a rosette is formed. So this is also a characteristic uniform population, and then you can make a diagnosis based on the pap stained smear, which will display that salt and pepper chromatin. Some would ask me, what do you mean salt and pepper? So think of a checkerboard or a chessboard, distinct pattern, dark areas surrounded by lighter areas. That's what the chromatin looks like. Generally, prominent nucleoli are not noted. Nuclear molding may be rarely noted, but it is not a feature. Main thing is take home message, various subtypes of as far as the shape goes, but predominantly the plasmacytoid cells would be noted, and synaptophysin, chromogranin will confirm the diagnosis. Carcinoid tumors can also be primarily spindled, but again, low malignant potential. These tend to be more peripherally located when they are purely spindle. So expect to see that in that scenario. This is a histologic resection. Mainly when you have histology, you will see an organoid pattern, meaning thereby distinct cellular tufts surrounded by capillaries. So that's basically what the impression is, even at low power. But with the well circumscription gives you a clear indication you are dealing with a carcinoid tumor. And basically, you would expect to see rare mitotic activity or no mitotic activity. But if you look hard and fast, then you may find something like 1 to 2 mitoses per 10 high power fields. But other features that should be looked for are presence or absence of necrosis. Common knowledge, all the books mention it. These tumors should lack necrosis. And that's something you should look for in your smears as well. Atypical carcinoid tumor, which is now is great as mentioned as a grade 2 tumor. If you look at the WHO classification, a slightly different morphology here. These tend to be slightly larger cells. The pattern is such that, again, they have an organoid configuration on histology. Hence, you are going to see larger groups of cells which are tightly adherent to each other, slightly larger than what you should expect to see in carcinoid tumor, and a lot more variation in the shapes. These don't tend to be necessarily plasmacytoid in appearance, but more rounded, more oval, or a mixture of all these cell patterns. But the organoid pattern is the most important. This is actually a resection. Here what you see are these tumor cells, and this is where the tumor is. The organoid pattern is quite distinct. Nice little nest separated by capillaries, but internally over here you start seeing some histiocytes, and then this is the focus of necrosis. So think of the needle going in. If the needle comes here, you will have this, you will not have this. You will end up calling this as a carcinoid. However, if it is more deeply placed and this is also sampled, then basically you can really call this out as an atypical carcinoid. So that's where the dilemma comes in, that for cytologic samples, sometimes we really cannot make a call between carcinoid and atypical carcinoid. So again, use your judgment given the specimen type. Comedo type central necrosis may or may not be found. So it's good to give a differential, and that's what I would advocate for you in your practice. If it's a fairly standard case with just plasmacytoid cells, bland morphology, you can certainly heavily lean towards a call for carcinoid tumor and less so for atypical carcinoid. But talking to surgeons, generally they are really not too interested in the cytopathologist really making this confirmatory call between the typical or the atypical carcinoids. They are probably going to take it out depending on the size of the tumor itself. So that's basically the take-home message about the carcinoid tumors. Small cell neuroendocrine carcinoma, again, I think this is fairly an easy call in a well-sampled specimen. specimens are very cellular. The cells tend to really squash up and give you this almost like an azopardy effect. I mean, this is basically giving you quite a bit of artifact, but the size of the cells tends to be small, about 3 times the size of a lymphocyte. Most of these cells are in that size range. They can form rosettes. They can give you no nuclear molding. But main thing is, not all small cells are small cells. There is also an intermediate cells, which is slightly larger. So, I mean, you have a predominant population of those intermediate cells, meaning not just 4 times the size of a lymphocyte, but more like 6 to 8. Then think of more an intermediate pattern, but your diagnosis still remains the same. That is a small cell neuroendocrine carcinoma. So it's a variation of size from really small to more intermediate. The key is they should not really be huge or large. More on that. So small cell neuroendocrine carcinoma will certainly have scant cytoplasm, but nuclear molding and characteristic nuclear details are the key. Again, this is giving you a real clear outline of what the nuclei should look like, really molded, high NC ratios, and then really quite characteristic neuroendocrine differentiation displayed by the chromatin pattern that you note in these images here. Confirmation is important. So one stain is important, such as synaptophysin. If you have chromogranin, you can certainly use that. One of the newer stains that have come out, which are nuclear stains, are INSM1. If you have that, you can certainly use that to confirm the diagnosis. Large cell neuroendocrine carcinomas, these tend to be rather rare entities. This is what the image looks like. The nuclear details are very similar to what you see in small cell neuroendocrine carcinomas. The characteristic neuroendocrine chromatinic pattern, it's just the size of the cells. These are really large cells, say 10 times the size of what a small cell would look like. So that is basically the key. The other issue is that this would be heavily infused and surrounded by necrotic debris, and also prominent nucleoli can also be noted in some of these malignant cells. So that's where the pitfalls can occur because of the prominent nucleoli, that an adenocarcinoma may come in as a differential. So keep those features in mind. I'm showing you various images here. Once you see it, you would be able to find quite a few groups which are displaying you cells which are really much larger in size than what you would expect to see in a small cell carcinoma. I wanted to show you basically this chart. So this is basically a size comparison of large cell neuroendocrine carcinoma with poorly differentiated squamous cell carcinoma and poorly differentiated adenocarcinoma. So the differential between large cell neuroendocrine carcinoma and poorly differentiated adenocarcinomas are the ones to be really considered. There's quite a bit of overlap of some of these features because the presence of prominent nucleoli. But main thing is the nuclear membrane. The membrane in the large cells tends to be very thin, and in the adenos, it tends to be very thick. So this is a good feature to keep in mind. But remember, some of these can be combined tumors to have components of both. So the cytopathologist has to work with these limitations. So there comes into play neuroendocrine IHC markers, and if you apply those and most of your tumor cells stain positive for synaptophysin, you can comfortably make a call of a large cell neuroendocrine carcinoma. Other considerations for the malignant category, this is a low power image of this next tumor. Any takers? I mean, let's see. I think I've given the diagnosis here. Bad of me. But again, what I'm trying to tell you here is that metastatic tumors, I mean, the lung is a very vascular organ in its own way. A lot of tumors through vascular dissemination can find their way there. So HCC metastasis tends to be rare, but in this case, it was present. And again, polygonal cells, granular cytoplasm, confirmation with arginase 1. This is the next tumor. Again, very pleomorphic cells, dispersed cells, large cells, small cells. And this is basically showing you a really large prominent nucleoli, which are cherry red in appearance, at least to my eyes. So I think I gave up the answer there. So do a stain, SOX stain is good. Metastatic malignant melanoma would be your answer. Mainly, I'm trying to basically convey to you that it's not just the primary malignancies that I've talked about, look for metastatic disease, but again, use your cell block judiciously because you have to conserve tissue for NGS testing. Enough that you can get 15 unstained slides out of your cell block material, which can be sent for NGS testing if needed. So with that, we come to the concluding case. So in the next couple of minutes, let me go over this. This was actually a very interesting case. And the key here is actually the radiologic presentation. It is a solitary nodule. It is well circumscribed. It's small also, about 1.6 centimeters. It's FDG avid. It's in the right middle lobe. Low power view. I'm going to test you now. You've been listening so attentively, so you should know all the tumors. So obviously quantitation is not a problem. It's got plenty of tumor cells, quite vascular there, some hobnailing, blood vessels traversing through it, size variation, free floating cells in the background, high NC ratios there, small cells, large cells, doesn't look like squamous cells, higher magnifications, more polygonal in shape, but rounded cells are there. I mean, look at the variation here. This is a distinct group here, giving you an impression that some of these are more rounded, smaller. These are larger cells with more prominent nuclei and nucleoli. Again, kind of looks like an adenocarcinoma, don't you think? I mean, here's another view. Going to show you plenty of pictures. So again, really a very high magnification, traversing blood vessels there. But again, I mean, very distinct cellular configuration, very epithelial or rather epithelioid, kind of given that location and configuration, I would say most likely an adeno, right? So this was the other smear we have. Again, gives you a papillary configuration. There's a somewhat of a dense material here too. I don't know what that is. Kind of reminds me of hyalinization, but individual cells are also scattered. Take a look at here, at this group over here. Large tufts here, but the cells which are at the periphery are giving you a hobnailed appearance and gives you an impression of being slightly smaller. This is the cell block. So again, illustrates the vascularity, somewhat of a hint of, hyalinization there, but cell types are more or less the same. Another cell block area, distinct groups there. Highest magnification for the non-believers. Okay, take a look here, but take a look at the periphery here. I mean, there is a very subtle hint here that some of these cells are a little different from the ones present in the center there. TTF1 was done. I've been propagating this as a marker for lung adenos, so I think it's a slam dunk case. Napsin, this is another marker used for lung primary tumors, but here there is staining here, but some of those cells are not picking it up. But again, I think we can call this positive. So 2 stains used. We have an answer, diagnosis. So what's the call? Wow, awesome. Okay. So this was a case in real time, was called out as an adenocarcinoma. Not by my practice, it came to us as a consultation case. But the reason for that was that the patient was not convinced. This lady actually sent this case over and we basically resected it. We reviewed the cytology and we disagreed with the primary, just like yourselves. But again, just to kind of recap, what the right middle lobectomy showed So a distinct tumor, but again, even at this power, this tumor will be characterized by these channels of vessels displaying blood right there. But again, a very distinct population of cells there at low power. Higher magnification, these are anastomosing channels connecting to each other. Look at the outline of the cells, hobnailing effect. Inner groupings are slightly different. Highest magnification. And then this kind of confirms it, that almost all the cells are confirming TTF1 positivity, but napsin is picking up only the peripherally placed cells, which are a little different. So that is the key. And then cytokeratin 7 is displaying the same features such as napsin, a distinct subset. And as you all know the answer, you know the IHC profile. So based on this, this was called out as sclerosing pneumocytoma, and we were able to successfully take care of this. So a few details. I mean, main thing is that has been well known since 1956. Initially was called out as a sclerosing hemangioma. I'm sure this is a very characteristic case review for presentations like this, but I'm glad I'm speaking to a very well-educated and well-trained audience, and you were able to nix the diagnosis. So again, I mean, just more images. Main thing is it's a dual population group. There are surface cuboidal epithelial cells and inner placed round polygonal cells. And again, it's a very subtle determination for cytopathologists, but for whoever this individual was, who will remain nameless, who called this out as an adenocarcinoma, at least the right treatment was given, meaning thereby no preemptive chemotherapy was given, only a resection was done, and the patient was completely cured. So again, more images. These are some really nice images I caught from my own case, which we did call it. And here the prominent stroma can be identified if it is present and can be noted even at low magnification, accompanied by these papillary configurations. Just like your cells, I think most practitioners would be able to identify and give out a diagnosis quite easily. And again, this is another image giving you a characteristic IHC appearance with all the cells picking up TTF1 and CK7 being positive with this outer lining rim, and nicely displaying the same cells here as a separate second subset of this dual population noted in this tumor. And this is a comparison of a cell block with a biopsy with pulmonary adenocarcinoma. Individual cells, if you look at them, they certainly do look the same. But if you utilize your skills as well as IHC, you can certainly separate them. So this is the summation slide, and I think I'm right on time at 12:15 to complete this session. So basically, failure to recognize the not so obvious sometimes can lead to a pitfall, and this would be one of the most commonly encountered scenarios that you may see in some practices, and it's best to be noted for lung cytology as a pitfall. So with that, I really thank you for your time, and open invitation, come visit us in New York. It is the Papanicolaou Lab. I would love to have you over and host you, and hope to see you the next time. Best wishes.